So, hi everyone, and welcome to PRS Journal Club Live. My name is Amanda Sergesketter, and I'm joined by my co-resident ambassadors, Chris Kalmar from Vanderbilt University and Ilana Margulies from Georgetown University. Thank you for all of you who participate in the PRS Journal Club every month. We are so proud to continue this tradition, and because of your engagement, PRS Journal Club has won several prestigious national publishing awards in the past several years, including Best Online Community, Best Education Campaign, and Best Podcast. Listen to the PRS Journal Club podcast on iTunes, Spotify, or prsjournal.com. Today, we have the exciting opportunity to be joined by Dr. Brett Phillips. Dr. Phillips is an associate professor of plastic surgery at Duke University, where he also serves as the director of oncologic reconstruction, co-director of the Duke Facial Nerve Clinic, and the residency program director for the Integrated Plastic Surgery Residency. Dr. Phillips obtained his undergraduate degree from NYU, followed by his MD and MBA from Stony Brook University, followed by general surgery residency at Stony Brook, plastic surgery residency at Duke University, and microsurgery fellowship at the MD Anderson Cancer Center. His clinical interests focus on head-to-toe complex microsurgical reconstruction and facial reanimation. We are very lucky to have him today, and thank you so much to Dr. Phillips for joining us on this PRS Journal Club Live. The article we'll be discussing today is entitled Facial Reanimation in Moebius Syndrome Using Bilateral Free Gracilis Transfer, 1-Stage versus 2-Stage Procedures by senior author Dr. Alexander Cardenas Mejia from Mexico City, Mexico. As a quick reminder, this article, along with all of the articles that are discussed in this podcast, can be read for free on prsjournal.com, including an archive of all the past Journal Club articles. So as an introduction, Moebius syndrome is a congenital condition characterized by facial paralysis and limited ocular abduction due to congenital underdevelopment or absence of cranial nerves 6 and 7. Traditionally, treatment for this congenital disorder has consisted of bilateral free functional muscle transfers using the masseter nerve as the donor to coapt to the obturator nerve, and typically using the gracilis muscle as the preferred free functional muscle. These procedures for bilateral cases are typically performed in 2 stages, with one side performed before the other. However, using 2 stages can pose both social and financial problems for patients, particularly in low-income areas where follow-up and multiple surgeries are particularly challenging for patients and their families. Thus, the aim of this study was to compare a single versus a 2-stage approach to bilateral facial reanimation for Moebius syndrome, specifically comparing safety, long-term outcomes, and cost-effectiveness of a single versus a 2-stage approach.
So, going into methods, this was a single-center retrospective study that was conducted at a specialized center in Mexico City from 2016 to 2024. Inclusion criteria included patients with complete Moebius syndrome confirmed by physical exam, genetic testing, and neurophysiological studies who underwent free gracilis muscle transfer either as a 1-stage procedure or a 2-stage procedure. And a minimum follow-up of 3 years was another requirement. Postoperative photos and videos were analyzed, and commissure excursions were compared using the 2-smile excursional scales. Patients also completed a postoperative survey. Total hospital costs were compared between the 1 and the 2-stage procedures, and the authors also described their approach extensively in this manuscript. The 1-stage technique involving 2 teams are working simultaneously, one on the face to expose the recipient vessels and one on the thigh, and then switching teams later in the procedure. They described their postoperative protocols with patients hospitalized for 5 days, and all patients followed a protocol for their rehabilitation.
Going into the results, out of the total of 60 complete Moebius patients, 18 met the inclusion criteria and underwent either 1 or 2-stage free functional muscle transfers for facial reanimation, including 9 patients undergoing 1-stage reanimation and 9 patients undergoing 2-stage reanimation. Across the cohort, median age at the time of reanimation was 15, and the masseter nerve was used in the vast majority of cases. There was 1 incidence of flap loss in the 2-stage group, and there were 3 hematomas in the 1-stage group as compared to none in the 2-stage group. Unsurprisingly, total operative time and length of hospital stay were significantly longer in the 2-stage group, and total costs were nearly double that of the 1-stage group. There were no significant differences in rehabilitation time or adherence to rehabilitation protocols between the 1- and 2-stage approaches. There were overall no significant differences in functional outcomes measured using the 2-smile excursion scales between the 2 groups, with about 30% incidence of good results, 50% incidence of moderate results, and 20% incidence of unsatisfactory results in both groups. Finally, there was no significant difference in patient satisfaction between the two groups.
So overall, I think this was a very interesting retrospective review out of a facial nerve center in Mexico City, Mexico, comparing outcomes between 1- and 2-stage approaches to bilateral facial reanimation for Moebius syndrome. Overall, the study showed that outcomes were largely similar between the two techniques, with the added benefit of reduced operative time and costs for patients and hospitals. The 1-stage group did have a higher rate of hematoma, which was unsurprising given the additional operative sites. I do think one of the findings that a high proportion of patients, or 20%, regardless of technique, had unsatisfactory results measured using the 2 validated SMILE excursion scales was interesting, as it shows that regardless of timing of surgery, more research is needed in this field, in particular, to improve outcomes of facial reanimation in this population. One of the drawbacks of this study is the small sample size, which is a drawback in all facial reanimation studies. However, I think overall the authors are to be commended for performing this study and including both functional outcomes and patient-reported outcomes. And I do think that this article shows that a 1-stage approach using 2 surgical teams may be a good way to get patients on the road to rehabilitation faster. So Dr. Phillips, thank you again for joining us today on this PRS Journal Club Live. To begin, what are some of your main thoughts and takeaways on this article?
Well, first, thank you for having me. I thought this article was great. I mean, I think you pointed out some of the flaws, but some of these flaws really can't be, not dealt with. I mean, this is a very, very rare, disorder, having bilateral facial paralysis. Obviously, just trying to compare, like with like, it's hard. I mean, 9 patients on each one, so it's definitely a small sample size. The age group, it goes from, pediatrics to adults. So you're not necessarily comparing all the same things, but these challenges you really can't overcome. But ultimately, I think they made their case that, doing everything in 1 stage is feasible and can be done. My thought just in general on the technique of doing it all in one, I mean, it's a lot of surgery. I mean, doing both sides at the same time. I mean, it's a big operation, it's a complex operation. There are a lot of pros to do it. It obviously makes sense that everything is half, as far like half the cost, half the time in the hospital. I mean, those all make sense, right? But the thing that you pointed out was, is it really true that if the results are maybe a little bit better if you did it in stages, or is it just good enough that you have everything done in one and then the patient doesn't have to come back and have another big operation? I think depending on who the patient is, what their situation is, I think this is a big center in Mexico City, as far as I believe, and they get people from all over. And maybe it's difficult to get patients to come back and have a second operation and go through all that. So like I said, I think it's a great paper. Just it is a small sample size. I don't think it's going to get any better. I feel like I've seen 3 Moebius patients in the last 8 years. I think I saw 1 adult patient that I didn't even operate on, and she was, I think, in her 40s. I don't think anybody even told her that she had Moebius. And as far as kids, I don't have my own pediatric clinic, but I work with Jeff Marcus, is one of our pediatric plastic surgeons, who basically taught me everything I know about facial reanimation and facial paralysis. So, and he sees a couple, right? So this is very, very rare. I think it's great to know that this is possible, and it's not totally offset as far as complications and risk, but I think it's possible. I don't know if that's something I would want to do, but I'm glad to know that other people out there are doing it and it is possible.
Yeah, I think those are great thoughts. And I think we know from our own facial reanimation research that the low N is hard to avoid in this patient population. Ilana and Chris, any other thoughts about this article?
Yeah, thank you for a great discussion so far. Yeah, I agree with you. I think that it's hard when it's, such a small number of patients. One thing, though, I think that the authors pointed out is their catchment area is very large, and it seems as though they're getting a lot of folks who are coming, from all over Mexico, low socioeconomic backgrounds, who may not be able to make the trip twice. So I think that, thinking about it from, like you said, the patient perspective of maybe patients can't actually come back again to get the second operation, doing this and showing non-inferior results, I think is really great and shows that, it can be done, especially in these kind of circumstances.
Absolutely. I couldn't agree more. Thank you so much, Dr. Phillips. 3 points that really stand out for me. One, like we said, is really keeping in mind the patient population, that these patients are traveling so far away that this really ensures their continuity of care and to make sure that their care is complete. Second, I think the author should be commended on their team approach, the way they switch between the thigh and the face and then alternate. That was really elegantly described. I think that's also something that we need to keep in mind is you really do have to have a big team to be able to do this. And then three, regarding the sample size, the reason their sample size was so small, of course, not just because of the incidence of disease, is because how strict their inclusion criteria was. They had dozens of extra patients that they treated similarly, but because they were so strict about their follow-up time, et cetera, is why the cohorts became what they were.
Yeah, and that's a great point, Chris. I think it also speaks to perhaps even what we were talking about before, the socioeconomic and people living so far away that their follow-up time, was so low that people couldn't come back to follow up. Probably speaks to the fact that this kind of intervention and doing it in a one stage is particularly needed in that kind of community. Dr. Phillips, what is your typical protocol at Duke for facial reanimation in patients with bilateral Moebius syndrome? Even in the couple of patients that you said that you've seen, and do you typically use a two-team approach, as described in this paper? And what are your preferred recipient vessels and target nerves?
Yeah. So we do have a team approach. We have 2 faculty members. So because a lot of the patients were pediatric, Dr. Marcus would see these patients ahead of time, and these weren't necessarily Moebius, these just be unilateral congenital facial paralysis, but he would see those patients, and then I would get involved and meet the patient, and basically we would set up a combined surgical date. So two teams, I think, is critical, and it just makes the day go by so much better. I think it cuts down on amount of time in the operating room. I think it's a more enjoyable operation to be with more people and to get things done and learn from another expert in the field. But having somebody on the facial aspect, so in my practice, Dr. Marcus would be at the face. He'd elevate the facial flap. He would dissect out the masseter in a case of Moebius. So dissect out the masseter nerve, have that ready to go. And I would be on the thigh and dissecting out the gracilis. And then we would actually switch places where once I had the pedicle dissected out and ready to go, and even some of the muscle cut to size, we would switch. I would go up to the face, get the blood vessels out. So we'd go to the facial artery and facial vein. I think it's critical as a microsurgeon. I love Dr. Marcus. I love other surgeons, but I want to be the one dissecting out my own vessels. I know what I want as far as length and caliber. So I think that's incredibly important for the microsurgeon to do. So that's where we switched. And then we would switch back again, go ischemic, bring the muscle up, hook the muscle up, do the nerve coaptation. But I think 2-team is great. Now, if you were to talk about what they did in this paper, which I think is what they did, I think both teams were either microsurgical trained or craniofacial trained, and it seemed like they just switched roles. It seemed like the team would go up and start the face side, and then the other team would start harvesting the other flap on the other leg, which is awesome. And if you can have a setup like that, that's great. I think that's probably a little bit more on the rare side, but if you can do that, I think it definitely would cut down more time and potentially make things run faster and smoother. And I think we got all the things. So facial vessels, I know some people use superficial temporal vessels also. I haven't had to do that. I've used facial vessels. I even had to go sometime into the neck. Superficial temporals, I think if you're going to do that, you have to change the way the vessels or the muscle lies, I think, a little bit to try and angle in that direction. And then also the superficial temporals go superior, and to try and get that to hook up, you kind of have to get enough length to turn them down to be able to get them. So I'm worried the lie is a little bit off. But that is a great backup if the facial vessels aren't working. And then the masseter nerve, you dissect that out. You try to get as much length on that and you have to flip that out of the little hole that you made into the masseter muscle, and then you can connect the obturator nerve to that. And usually we have a lot of excess of obturator nerve, and I think you want to make sure you get rid of a lot of that excess, because that will add to the time as far as how long the axons will take to grow from the masseter into the gracilis muscle.
What are your thoughts about going in? Some people use spinal accessory or some people use hypoglossal. What are your thoughts about those?
Yeah, I have not used spinal accessory or hypoglossal, although, at this recent facial nerve symposium I was at, more and more people are continuing or using hypoglossal more. Hypoglossal nerve, what they do is they'll cut into the hypoglossal nerve. It'll be more of an end to side anastomosis, which, I mean, I think you can do because you can get enough length on the obturator to go down to the hypoglossal without having to use additional nerve graft. But they cut into it about a third and then do like an end to side into that. That way it doesn't create as much morbidity with the tongue, and the hypoglossal nerve provides tone and motor, and masseter is really just motor. So I think there might be some benefits to that, but you have to really play that with the downside of the morbidity for the tongue.
That makes sense.
For cases that are not congenital, can you describe your typical approach to facial reanimation, and at what time after paralysis do you consider free functional muscle transfer as opposed to nerve transfers?
Yeah, so I would take this maybe not for not a congenital patient, right? So in a adult patient, typical scenario, and I would take out like Bell's palsy and Ramsay-Hunt and those kind of things. If we're talking about some kind of skull-based tumor, acoustic neuroma, schwannoma, those kind of things, we have a great relationship now with our skull-based team, and they let us know when they're operating on a patient and will tell us basically if this patient has post-op paralysis, what happened. The biggest question is the nerve cut. Is it out, or was it perfectly fine and maybe there's just some neuropraxia? So I think depending on those characteristics, if the nerve is just cut and they never hooked it back up, then you can kind of go a little bit faster on that. But if the nerve is intact and maybe it was just injured from traction or a thermal injury or something like that, I think you do want to give it some time to grow back. So the data supports waiting approximately 6 months and assessing facial nerve recovery. If the facial nerve starts coming back and you feel like you're getting some movement of the face, you'll get some improved tone from flaccid to just a better resting position. If you get that by 6 months, there's a good chance that you'll actually get more meaningful recovery. If you do not get anything by 6 months, the data supports that it's not going to be that great if you wait a year or more. And then ultimately you're in a time game that you have to get those muscles innervated by 18 months approximately. I mean, you could say 12 to 24 months, but you need to get those innervated. And if you're talking about doing masseter, babysitter, and cross-face nerve grafts and things like that, those all take time to start reinnervating. So doing a 2-stage operation with 2 cross-face nerve grafts, masseter transfer, that's going to take like a year to get all of that done. And then if you started at 6 months, it's 18 months by the time that's hooked up. So when we see patients in that setting, we see them close to 6 months. We kind of already have an OR date booked for them right around that 6-month mark to try and get to reinnervate their muscles before denervation.
So do you think there is any challenges associated with rehabilitation in patients with free functional muscle transfers on both sides of their face, particularly, in the single stage approach, if you were to have a patient that you were to intervene on both sides? And do you think, I guess there's a follow-up for that in my mind, potential problems being synkinesia or cortical remapping. Do you think any of that is affected by trying to do this in a single stage on both sides?
I mean, as far as post-op recovery, I mean, if you do more surgery and you put gracilis on both sides of the face, I mean, I think just the post-op recovery is going to be a little bit more challenging, right? So, having a soft diet, you can't even chew on one side of the face, right? So it's going to be a soft diet for a while. And as far as, you're really waiting for masseter to grow into the obturator, into the gracilis. And if it should be a much shorter time period because the distance is not that far. So by 3 3 months or so, you usually start seeing some kind of movement. And the moment you start seeing movement is when you start doing, physical therapy and smile therapy. And, uh, honestly, I don't, you the way to innervate or the way to activate the muscle is by biting down, right? So they're going to be biting down on both sides. And I think maybe it might be a little bit more challenging to try and figure out, like, if I'm biting down more on one side than the other and activating one muscle versus the other. Um, I, I don't know if there's going to be that much of a difference, but I know the recovery initially will be a little bit challenging. But I think the post-op, like, therapy and all that kind of stuff still kind of remains the same.
There was a high incidence of unsatisfactory results in this study, which is something that I think most facial nerve centers experience. How do you think we as a field can improve our results in this patient population?
Yeah, so the doing everything in one stage, you don't really have that opportunity to go back and kind of maybe fix any issues and correct any problems. So some of the problems with the functional gracilis is, where do you place it? Where are your sutures around the commissure and the mouth and the face, and then, like, where are your more distal sutures as far as anchoring the muscle? Sometimes you get some dehiscence of that. You get maybe poor angle or trajectory of that muscle. I think it's incredibly important to make sure that whoever is anchoring and placing that muscle is probably the same person on both sides. I was actually talking with Dr. Marcus about this yesterday, and he said he probably think that's the most important thing. If you're going to do both sides at the same time, make sure that it's the same person putting it in. I mean, we do surgeries with multiple surgeons all the time, and, like, if one person is doing one side, one person is the other, there's going to be some slight differences. Like, that happens always, right? For this, it's incredibly critical, to have results where it looks symmetric on both sides. If you have two different people doing it, there's going to be some differences, right? So I think it's critical that it's the same person. So I'd say that, I think, is probably the most critical part of getting it right. And if you're going to do it in that stage, if you do it in 2 stages, sometimes the first side, works great, no problem. And then you go back, you don't have to do anything else on the first side. But I've done a bilateral where we've gone back and actually revised the first side when we started doing the second side. And then you can learn from your mistakes and fix it on the second side. Like, just maybe you didn't anchor the right place and you wanted a little different trajectory. You can do that. So I think that's maybe why you can maybe get a little bit better satisfaction.
Fantastic points. Thank you.
Just to follow up on that, what are your most common, like, revisions? Like, what are the patient complaints when they're coming back to you asking for revisions, and then what are you most commonly doing to correct those operatively?
Bulk is definitely the biggest one. So, I think it's a little anxiety provoking taking this tiny little muscle flap and then trying to make it thinner or way less and not add to the bulk of your face. So some people just plan on doing revisions and just say, you know what, it's going to be bulkier. We're either going to go back in and we're going to debulk it and take the top layer of muscle off later, or we're going to do it at the same time and potentially maybe fat graft or do something to the other side of the face. So that's probably the most common, but you do get patients where there might get some, like, commissure dehiscence, or maybe the angle's not right, and you can go back in, elevate the face. You find the muscle pretty easily, and you can release it and just kind of, like, change that position. So that'd probably be the second, but I think the bulk is probably the biggest one.
And I guess if anyone has any questions from the audience.
Hey, Jesse Chow from UVA. Thanks for the great panel. Where do you feel like, in general, like, where these patients are coming from in terms of referrals, and do you work with ENT at all? At UVA, ENT is kind of doing most of the facial reanimation stuff, but curious to hear other people's experiences. Thanks.
Yeah, so there are a lot of facial plastic surgeons and ENT surgeons that do this operation across the country. So there are definitely a lot of groups doing it, but when you think about it, it's still a small amount of centers, and it's a very small patient population. So each place is just getting a small amount of these patients. As far as our practice, so we have a facial nerve clinic that's a multidisciplinary clinic, and for adults, it's myself and a facial plastic surgeon that's part of ENT, and he functions to help, and we split the cases. We see all these patients together, and in our practice, he takes care of the facial elevation, the master nerve harvest. some of the cross face or finding facial nerves, doing cross face nerve grafts. So we kind of share, and I think it's great collaboration between the two groups. And you got to think about referrals. Where are they coming from? A lot of these patients, especially Bell's palsy, skull base, that's all coming from ENT. So the referrals will potentially go to them first, unless you've established this, referral pattern at your institution. So I think if you don't have it, I mean, I think you want to just join the group that has it and build relationships and collaborations. And I think you can really have a great practice working with a multidisciplinary group.
Thank you guys. Great discussion and great paper. The authors mentioned they don't have a standard algorithm for deciding one stage versus two stage. Is there anything you would consider in deciding between the two, or something you'd like to see in that algorithm if they decide to move forward with the prospective study?
Yeah, that's, I think, one of the issues of the paper, right? Like, why did they pick one versus two stage? And I think I bet it was based on, patient considerations. So somebody maybe traveling from, 12 hours away, or a plane flight, they're like, we're just going to get it done in one. And I'm sure the patient probably said the same thing. You also got to talk about follow-up and all that kind of stuff. So I think that's probably what that was. For like our practice, I mean, we have a catchment area that goes all over the Southeast. So, but there's multiple big institutions that do this surgery, but we'll get patients from, at least for North Carolina, we get them from Florida and Georgia, Tennessee, Virginia. And so they still have to travel a good amount. So you really got to plan this out for them and try and make sure that they stay around after the surgery a little bit and not travel 12 hours back to wherever and they have problems. That was actually one of my first patients, was from Florida, and was like a 12-hour drive, and they had a complication, and I basically said they had to just drive back. And I mean, that's a lot. So that might be a patient, if it was a Moebius, like say, hey, maybe we just do everything at once.
Any other questions from the audience?
I would actually ask the three of you, what would you rather do? Would you rather do it all at once?
All at once.
You'd rather do everything at once?
Yeah.
Okay.
Yep. Likewise, all at once, because I remember the tension I put on each side, and I can,
Okay.
really, yeah.
Well, you can have it seen right here. Great. Okay.
I think for me, it may depend on where I am in practice. I think all at once, like you kind of said, it's a lot of surgery. And I think that, at the beginning, of practice, as I kind of think about going into practice at this point, I might say, maybe I'll two stage it just for my own kind of my own edification, making sure that I can do this all in one stage confidently, like you said, making sure that, we don't need to revise anything. And then maybe as I get better at it and get more competent and faster, because like you said, it's a lot of surgery, especially if it's a child, to put them through, I may, then progress to more than one stage. I think that also, like you said, patient factors is probably going to be a very big thing in terms of whether or not they can come back. And I'll probably plan.
And then if you did both sides at once, now you guys want to do both at once, right? What if they come back and one side doesn't work? One side smiling, looks great. The other one does nothing.
That was my question about this article, is what happens if it doesn't work? And I think then you have to consider a secondary free functional muscle, but certainly that would be a very...
Let me tell you, that is not easy.
Challenging, yes, I know.
Yep. And then, you're talking about like trying to find a different type of functional muscle to replace that. And then maybe at that point, it's going to be hard to go back to the same nerve. So it's going to be hard to find the masseter nerve and reuse that. Or maybe then you got to go to hypoglossal or spinal accessory, something different. It's really challenging. And I feel like if you're going to do, if you stage it and do two stages, like the first side, if it works, great. Then you feel better about it, right? You go to the second one and you would hope the same thing happens. But I have experienced, I think, both. It's challenging.
Can I ask your thoughts about, salvage options in those situations? What would be your secondary muscle to go to? Like, can you bulk down a latissimus? It just seems like kind of a crazy thought, because the gracilis is so perfect and it's so classically described in this situation. But what are your thoughts about secondary muscles?
There are other options. The thing is, you don't even do a lot of these. You don't do a lot of these in training. I went to an excellence fellowship, and I think we did maybe one, for adult oncologic reconstruction and using gracilis, right? So then you're talking about using latissimus, serratus, and then pec minor. And I had this exact situation on a Moebius patient, and I went to go use their gracilis, and we were going to stage it, and I went to use the gracilis, and the gracilis itself did not have a like adequate blood vessel. So the obturator nerve was there, the medial circumflex femoral was just like absent. Looking back, I feel like I did something wrong. Maybe it just wasn't there. I didn't find it. Not sure, but like I was like, I have no idea what to do now. And then like I tried calling people, asking people, and we ended up doing a PEC minor, which very, very challenging. And that was my first month of practice. And these are really, really hard cases. It worked, but we needed to revise it. And then we did the other side, and the other side worked just fine. And I think, trying to think about doing all of that at once, if I was planning on one stage at that time, I mean, that would have been terrible.
When you did the other side, did you go PEC minor on the other side?
Yes.
Well, that's the other leg.
That was my other thought. Now it was like, so if one side fails and you got to pick a different type of muscle, these muscles act differently, right? So you're going to have one that maybe pulls tighter or is more bulky or whatever it is, and you have two different things on their face. Your ideal goal would be to have the same exact thing on both sides.
I think with the single stage approach too, it really advocates for needing a co-surgeon type model, because doing both free flaps simultaneously, I think would be very challenging. But
I agree. I think having a co-surgeon, having somebody else in the room, I think makes the operation flow better. It's more enjoyable, less anxiety provoking. I mean, it's actually really, really great.
all right. So with that, we will end our discussion of this article. Remember to tune into the 3 other articles that we will be discussing on this month's PRS Journal Club podcast, which will be broadcasted online. Also, don't forget to participate in our monthly PRS Journal Club on Facebook, where you'll be able to interact directly with this month's selected article's authors. Once again, thank you so much to Dr. Phillips for joining us.